Very, very good afternoon to all of you, my dear audience and followers, and also to our dear Haidar. Basically today topic in continuation with our previous series, which is the educational series of the MHRI series in reproductive medicine, is on the PCO. Many girls and many patients, married or unmarried, they are in dilemma. What is this PCO? That every doctor is labeling them as a PCO. Approximately the way things are moving, as if about 70-80% of our women population, they have PCO, but incidence is not so high. There was a task force which we were also we were participating in that national program of the Indian Council of Medical Research, and the incidence was found to be approximately 11 to 12% from all over India. Of course, it varies from state to state, but first let us define what is PCO. PCOS is defined if there are 2 out of these 3 criteria is present in any woman in reproductive age. The first criteria, if she has any evidence of the oligomenorrhea, irregular period, or amenorrhea, plus if she has any evidence of elevation of the male hormone like androstenedione or testosterone if it is elevated, and if on ultrasound image there are more than 20 follicles are there, a small follicle which is peripherally arranged, which the size is approximately between 9 to 10 mm. Or maybe the radiologist also including this ovarian volume, if it is increased also, that is added to the ultrasound imaging features of the polycystic ovarian disease. So if the woman, the patient has amenorrhea or oligomenorrhea, or she has evidence of male elevation of the male hormone like hirsutism, excessive hair growth, if she is obese, and if the on ultrasound it is showing peripherally arranged follicles, which there are more than 20 of these follicles are there, so then they will label the patient as a polycystic ovarian syndrome. Now we are classifying the patient as a phenotype A, B, C, D. In phenotype A and B, there are evidence of the high level of the androgenism and hirsutism and obesity. And phenotype of the C and D, where they don't have any evidence of elevation of the male hormone. In these patients, there is also elevation level of the insulin, where it is causing the black discoloration of their neck. And you see a patient very obese, the BMI is more than 35, and you see they are having black discoloration, they are having hair growth on their face, on their abdomen, on their thigh, and on ultrasound we see these features of the peripherally arranged follicles, so they are being labeled as a polycystic ovarian disease. Once the diagnosis is being made and patient has a high level of testosterone, high level of androstenedione, she has amenorrhea, she has oligomenorrhea, and she has an ultrasound feature, then we have to treat her. And treatment depends on what problem she has got. If there is an obesity problem, we have to put her on the lifestyle modification. They basically a diet, a good diet with a low calorie diet, and also exercise, where it will be about half an hour in the morning, half an hour in the evening, and BMI has to reduce at least maybe 10 to 20 kg they have to reduce. And if problem is with excessive hair growth, then we have to give them an OC pill. With OC pill, it prevents the ovulation, therefore the estrogen and androstenedione male hormone it decrease. And also basically the OC pill also stimulate production of the sex hormone binding globulin, therefore the free androstenedione and free testosterone will be reduced, and then the hirsutism get controlled. Or in some cases, dione 35 we give them, which has got a cypotron acetate, which is a basically testosterone antagonist, which is blocking the testosterone receptors. So this dione 35 also is very good to prevent the fresh hair growth, but of course cosmetically also they need to take the help of a beautician to remove some of this unwanted hair. So we said about the obesity, weight loss, lifestyle modification, hirsutism. These are the medication, OCP or spironolactone 25 mg 3 times a day, or they should go for dione 35. And also, if problem comes with the amenorrhea, we have to give them a progesterone to get basically a regular period. If we do not treat these PCO patients and allow them to have an amenorrhea, there is a possibility that they will have an endometrial hyperplasia, and then maybe later on in their age they will have an endometrial cancer. And these patients, because of high level of the insulin, they have an insulin resistant type of a diabetes, type 2 diabetes, and later on once they become 35-40 years. So type 2 diabetes also is one of the morbidity. Endometrial cancer also, and is a male baldness. They will have a baldness here because of high level of the testosterone and androstenedione. And the main problem is also with this patient after marriage, they will have infertility because they have a chronic ovulation. The first thing is we do is we have to make them lose weight, lifestyle modification, and put them on ovulation induction. Ovulation induction also is very useful. Clomiphene, we give them 50 mg, which clomiphene in this PCO patient, they will have basically approximately, if we give them 6 cycles of clomiphene challenge, so they will have approximately 40 to 50% cumulative success rate and ovulation and pregnancy. And if they do not respond, then because the quality of egg is poor, quality of egg, why it is poor? Because their oocyte is normally very granular, and because of high level of the insulin, therefore it's very important if they do not respond to any conventional treatment of ovulation induction or IUI or a high dose of the gonadotropin, then we have to give them a counseling about laparoscopy, and laparoscopy is one which basically it is like a LEOs, the laparoscopic endosurface coagulation. Very gently we have to do. Many of the our colleagues, they will do 3, 4, 5, 6 puncture, which is not warranted. 3, 4 more than enough if it is a very classic PCO. So in that, what happened, the stroma, once the cystic is burned, the LH come down, and then in about 30-40% they start doing the ovulation and useful. Then we can, after laparoscopy, we can again put them on the follicular study and ovulation induction. And if they don't respond to the ovulation induction or LHRH agonist, medical gonadectomy, laparoscopic procedure, then we have to give them a counseling about the ART and IVF. In IVF also, weight loss prior to the IVF is mandatory, and it's nice to know that we basically weight loss, it makes them give a better response to IVF because the insulin, the body gets more sensitized to the insulin, and the response become better, the follicles grow better. And also it is important to know these PCO patients are very much high risk for OHSS, ovarian hyperstimulation syndrome. Sometimes 40 eggs we remove from one egg, and they are very much at risk of OHSS, which they can have a big problem. That is why it is important to do segmented IVF. We take out the egg, we do the ICSI, we do the freezing on the blastocyst stage, and then after 1 month, 2 months, once they are settled, we do the embryo transfer. To conclude with today's session, it is very nice for all of you to know if you want to have if you are suffering from a polycystic ovarian disease, the first thing is take care of your diet, take care of your weight and BMI should be controlled, because whatever treatment we give, if obesity is there, then the response becomes very poor. But the obesity has to be controlled, basically lifestyle modification, gym, exercise, and basically activities, half an hour in the morning, half an hour in the 30 minutes. 30 minutes is very, very effective. And also a good diet, basically high fiber diet, is also helping them to lose weight. Before put them on ART, before laparoscopy, because if laparoscopy, the weight is 130 kg. It's very difficult to do the laparoscopy also. So that it is important to lose weight and change your diet, change your lifestyle, and it's going to be very helpful.